In the United States, we have actually, and when we think about cancer prevention, we may have the perfect intervention here. We have a vaccine series that requires, at the moment, 3 shots over a 6-month period with a near 100% efficacy against the infection and the diseases those viruses cause. So it's simple. It's not every year you got to come in and do a procedure and take time out of your schedule and so on. The other is, unlike other health services, now prior to the Affordable Care Act, a major barrier to cancer screening has been the access and the ability to access those health screening services. With vaccination in the United States, we have an entitlement program for vaccines, which assures that for all vaccines recommended by the Centers for Disease Control and Prevention, that all underinsured and uninsured children have access at no cost to those vaccines. So that means children ages 9 to 18 in the United States have no cost barriers to vaccination. So we have a perfect opportunity to implement a cancer prevention strategy that eliminates so many of the barriers that were problematic in assuring equal access and participation in cancer screening services. So you would think we would have a very high rate of vaccine dissemination. But unfortunately, that's not the case in the United States. Unfortunately, our rate of vaccine dissemination among females for the 3-dose series, completing the 3-dose series, is around 37%. And among males, now we've only recently introduced male vaccination, so we expect that's going to be lower. But among males, it's around 10%. So as a country, we need to become aware of this wonderful opportunity we have and help spread that message and increase the uptake of HPV vaccination. Now, dissemination of vaccine in the United States is a bit more complicated than what you have in other countries. So for instance, let's take Australia as an example. Their healthcare is organized through a Minister of Health that is centralized for the country of Australia. Once a recommendation is made, the Ministry of Health has the opportunity to develop a countrywide program for vaccination. And so what Australia did is they created a system of school-based vaccination countrywide. It looks like what we used to do in the United States, where for some of us who are old enough to remember, we would receive our measles vaccination or polio vaccination lined up in the schools. In the United States, we don't offer school-based vaccination. So it requires a visit to either the health department or a clinic. And then it also requires that the practitioner in each of those settings strongly recommends the vaccine. And between the combination of all those factors, it has conspired to essentially reduce the rate of vaccine dissemination. This has become a national priority of the National Cancer Institute. The President's Cancer Panel has focused on this as an issue. And number 1 on that list is provider recommendation. And so several of us around the country are working to help institute programs and educational systems, reminders and so on, to help the providers better able to make that strong recommendation and actually follow through with vaccination. When we had cancer screening, like cervical cancer screening, as our primary tool for prevention of cervical cancer, one of the things we learned very quickly is that provider recommendation was essential. But part and parcel with that was the acceptability of that message to the community. So it really is 2 parts. One is educating the community so that they're prepared to receive that message and act on that message when a provider gives it. And the other is to educate the providers on how they can simply and effectively deliver the message so that vaccination occurs. So I see public health workers potentially helping with both parts of that equation. doing general community education, as well as working with provider systems, whether it be in public health departments where vaccines are disseminated, in community health centers, in clinic offices, and so on. What can we say about HPV and disease? We know that HPV causes multiple cancers in men and women, as well as genital warts in men and women. In countries like the United States, the incidence of oropharyngeal cancer and anal cancer caused by HPV is increasing in men. And yet we have no screening that we can reliably detect those precancerous lesions and treat so that we can reduce the incidence of those cancers. So the most reliable way to prevent all of these cancers in men and women is through primary prevention. In other words, through HPV vaccination, which we have very strong evidence from both clinical trials and from countries that have been disseminating vaccine, that these vaccines will reduce the infection as well as the diseases that HPV causes. We know that the vaccine in the United States is publicly available at almost no cost. So unlike other health services that have cost barriers and access barriers, that does not exist for the HPV vaccine when delivered to children in the optimal age group of 11 to 12. We also know that the success of this vaccine program is heavily dependent on community acceptance of vaccination and receipt of a strong provider recommendation to vaccinate both males and females in the age group 11 to 12 and up to age 26 for females and age 21 for males. The promise of reducing up to 6 cancers that HPV causes in males and females can be a reality in the United States if we can increase the rate of vaccine dissemination to 80% or higher as per our Healthy US goals. Thank you.